Hi, my name's Paul Nathan. I'm a GP from Derbyshire. So I work 4 days a week doing clinical work. I've been a GP in the practice for 22 years. We have grown over that time from 6,000 patients to 18,000 patients. I'm a trainer, GP appraiser, and some of you may or may not know, I helped co-found the System 1 user group many years ago with another GP from Lincolnshire. So I'm passionate about how we use the information in our systems, because I think we don't collect it properly, we don't make use of it properly, and I'm still a great advocate for general practice. I've kind of been looking at this issue for a couple of months, I think, with Fiona and her team, and before then I wasn't aware of it. I don't know about you, I think most of my GP practices in Derbyshire aren't aware of this standard and what it means. Well, we've had a reminder about the standard and what it means and when it comes in. I've brought some data from my practice and some of the implications for that. I don't know whether other people have been able to bring data from their practices. This isn't about me telling you what to do. I think practices work individually. They have their own way of looking at their data. They have their own way of knowing how to use their systems that suits them and the training and the staff skills that they have. So I think it's about you coming up and having time in the next 40 minutes, I think, to look at some of the solutions that might help you do some of this work. And then obviously there's also the practical solutions you need about doing some of the stuff and talking to suppliers outside, and Fiona was going to talk a little bit about that. So as we know, this format comes in on the 31st of July and we've all just got to do it. So it's how can we do it in a way that doesn't impose too much work on us, we manage the work that's required, and we deliver the benefit for the patients. And in preparation for this, only last week I discovered BMA guidance on this. And I would say to you all, just Google the BMA guidance, because the one key message I took from the BMA guidance was, you haven't got to identify all 600 patients in your practice by July the 31st. What you've got to do is have a process for new patients. And you've also got to have a process for those patients who access your service. So if somebody comes in and they have a disability, they have a hearing or a visual disability, learning disability, at the time they access your service, you then record that disability and help them for next time. And that was the key message I took from the BMA guidance. And the key thing here is making this manageable. So if I look at, this is my practice data, I've got 63 patients who are registered blind or partially sighted. I've got over 600 patients who've got a code of hearing loss. Now that is because in the past, my clinicians did not realise that if you put hearing loss in, that code, well, it's now been used for this, but it's a code that we used to actually mean they got a hearing difficulty. And we just used it as if they got a hearing loss. So they're using it as a diagnostic code when they should have used a symptomatic code. So I've got to go through all those patients and actually determine who has actually got a hearing loss required to suit this standard. So that's why there's some background work for practices to do on this and to look at their own data and how they've used coding in the past. I've got 72 patients with hearing aids, but if I've got a hearing loop in the surgery, then maybe I don't need to do anything else for those patients. I've actually got one person who's registered deaf, but I've got 197 who've got sensorineural hearing loss. So we've not been using registered deaf as a code. I don't know how you get registered deaf. I don't know who decides it. I've got to do my homework on that. But it just gives you an idea of some of the data that if you had to go and identify all the patients now, before 31st of July, I'd have to go through all 600 people with hearing loss. I've got 138 with autistic spectrum disorder. I can't remember how many of those are adults and how many of those are children. And I don't know what their communication needs are with regard to this standard. But again, if they make access to my service, I can then start to consider that when they come in, either at the reception desk or when they're with the clinicians. And the same for the learning difficulties. I've only got 7 people with aphasia, and that's part of the standard. interestingly, again, the other day, I just looked up how many patients I got recorded as having patient information status, which is the high-level code required for all the stuff we're supposed to be doing with regard to this standard. And I got 12 patients already with that code, and I thought, where the hell have they come from? Actually, 10 of them had been registered at other practices, and they'd used the code for things like brought in marriage certificate. And so when I'm thinking of my prompts and the way I'm going to use templates and things in the future, I've got to remove that code from 10 patients because it's not applicable to this standard. So again, it's sorting out some of the data. It's like we did for QOF, isn't it? If you remember when we had QOF, we had to actually decide who'd got heart failure and who'd got all these other conditions and who'd got BMPs done, who'd had echoes done. It's going through that filtering process and refining your, I'll say disease codes, but your disease registers. So we'll move on because we've got an issue over how you do some of this and how TPP are not engaging to include the preferred communication codes within the new patient registration, which is what debate we've just had at this up here. So as you all know, there are hundreds of ways of doing things in TPP, and different practices choose to do things in lots of different ways. What we've got to is that we need ways of identifying these people, and practices are going to go away, do their templates, their prompts or their reminders. And this is an example of a letter that could go out to patients that Straight Talkers have produced. And you can have access to that. Now these are the information codes, the preferred information codes that we were talking about up here. And this is, you know, we were debating whether you need to code this information or not, and maybe what the advantages of coding that information and how you record it in the records. Because if it's not in the box, the preferred communication box that's already there, where does it go? How do you find it? And what do you do about it? So that's kind of probably where we need to carry on talking, I think. If you've got a code in here to say you've got a hearing loss or visual impairment or something, you get a prompt come up that allows you to put a free text reminder on the home page. It also allows you to put a free text comment on the prescriptions for a patient about their preferred method of communication. Okay, so this has been trialled in 4 practices in Yorkshire and Humber. When you go through that process, I've only put the front screen on there as to what you see. When you go through it, it tells you, it gives you a list of all the different methods of communication, and you edit them to add them in. So that there are more screens behind, you know, that if you carried on clicking, you would get more screens. But I didn't take screenshots of them all. I just brought the first one to show you. You know, because I thought, well, Yorkshire and Humber CSU have done that for you. If you don't know it's there, you need to know it's there, and then you can trial it and see if you like it. You know, it's getting that message out to practices that this has been done for you. It's been, as we said, Des has said, it's been trialled and the practices liked it. Right, so what I've been up to at my practice is I've actually created a view to put these codes in, and I've created status markers because I like to have status markers and a template to encourage our clinicians to do it. So I've set a view and put it at the top of my clinical tree there, so that, and within that view, if you have a code suitable for this, you will get a status mark, and the status marker is a big like dinner plate thing, gold dinner plate. It doesn't appear on here because Minnie Mouse, it didn't work. The status markers didn't work with her, and I've put the template in there. So hopefully then, if people can click on that, see if there's a code there, and if there is, you know, and they can add the codes by clicking on the template very easily. I thought that brought it together. So here I've got the codes. So again, what I've tried to do is the patient information code is, you know, might be the patient wants to be emailed, but then I've also put in things like actually the patient wants to have a British Sign Language interpreter present at the time of a consultation. Because I think you've got the two things going on, but the British Sign Language isn't part of the patient information status codes. So I've tried to do that for hearing, for vision, starting to think around it about learning disabilities, and then What I've also wanted to put in was actually the consent codes. We're supposed to be asking these patients if they can be consented to share that information under the additional summary care record to share it with other organisations. And I thought, well, my clinicians are not going to remember if it's not easy to get hold of. So I put a screen in there with the codes, and you've got codes for parents to give consent, for children, and for the patients to give consent. There's this whole issue around the summary care record, understanding what codes go in automatically out of this. Actually, I think there's whole issues around what should be recorded in a medical summary, and there's no national guidance on that whatsoever. And as part of that, I found this code being certified as partially sighted in England and Wales, and we've got nobody in the practice who's got that code in their record. And then, of course, there's the whole issue around how you gain consent to share this information from patients, and you record that in the records. And then finally, obviously, of course, we heard today about patients reading Braille and using technology. And that for me was fascinating because obviously, unless you've got those impairments, you don't know what's out there. I don't know how many practices here have tried emailing patients from records. It's a real difficulty. They can't email back in, and you can't kind of have a conversation with them, because I got a deaf patient who wanted me to email her, and that has proved really difficult, because unless they've got your personal email and you're prepared to have emails at 10 o'clock on a Sunday night, it's a real problem for practices.